We have to remove conflict in almost every area of business. And if you look at the industries that have done poorly, the restaurants, travel, entertainment, and then sports. And I just hope for their sakes and all the people that are suffering come together. So what do I want specifically for the Rothman Institute? I want to open our doors. I want to bring people who want to come into our offices. I want people who want to take advantage of telemedicine, take advantage. I want to grow the Rothman Institute because I think we have the right platform. I think when you base a practice on more than just excellence in clinical care, but in research and education, you benefit societies and communities you go into. So what I'd like to do is I'd like to see our business grow.
Hi, everyone, and welcome to the inaugural episode of The Breakdown with Rothman Orthopaedics. I'm your host, Alex Hammond, and today's episode I'll be chatting with Dr. Alex Vaccaro, president of Rothman Orthopaedics. He and I will discuss the strange year that was 2020 and looking towards all the exciting things in Rothman's future in 2021. Next up, we will chat with Dr. Danielle Ponzio. She is the only female joint replacement surgeon we have at Rothman, so I'm excited to discuss with her professional career in orthopedics as well as get to know her personally. Last up, in a segment called Medical Incredible, we will talk with hand and wrist surgeon Dr. Asif Ilyas about the benefits of having a hand surgery with no anesthesia. All right, very appropriate that our first guest is Dr. Alex Vaccaro. He's the president of Rothman Orthopaedics, and thank you for joining me today.
Thank you, Alex.
You're welcome. And I wanted to read this quote I found from a few years ago when you were first named the president of Rothman, and want to see if it still applies today. We are entering into a period of clinical transformation where we will continue to provide the best evidence-based medicine for all orthopedic conditions. We will do this continuing the principles of quality, service, and cost-effectiveness established by Dr. Rothman.
I totally agree with that statement except for one thing.
What?
I'm a lot grayer. So things have definitely changed. And thank God this is not a visual podcast. It's a hearing podcast only. But no, that we're based on value-based healthcare, which means that everything we do, we have to make sure it's not redundant, wasteful. There's evidence to support its use. We always have to be conscious of costs because if we don't have what we need to pay for healthcare, we won't have the appropriate healthcare for the masses. So we've entered into an interesting era, and it's been spirited by Dr. Rothman, who ever since I was a resident with him back in the 1980s always said, we need to have evidence, we need to have evidence. And we get evidence through many different ways. We get evidence through research studies, we get evidence through registries, we get evidence through experience, but we have to make sure we critically evaluate that evidence to make sure what we do is effective for patients and not wasteful, because we have limited resources in medicine.
So one of the things, again, that I really liked about this quote was the period of clinical transformation. And I think specifically if we want to just kind of like look back into 2020, and that was a time, I think, in the beginning of the year, we all went into the year with one sort of expectation, and then COVID hit, and then we kind of had to regroup, stop, and figure out, what is it that we were doing. So when COVID hit last March, what were you kind of like, you sat down with leadership and you threw plans out the window? Like, what did you do to kind of re-strategize and kind of get that going?
That's a multifaceted question because we were heading along, and I think that we got word that we had a clinical problem, pandemic, I would say, in February and March. I mean, they called it a pandemic in March. So we were, expanding, we were hiring physicians, we were investing, we were opening up offices. We were taking on debt that we financed ourselves. We didn't go to the capital markets for debt. And all of a sudden, this pandemic hits, and we have to close. We go from 41 offices to 12 offices. We have to furlough 1,300 employees. We have to furlough 60 physicians. We don't have any revenue coming in. I mean, we were looking at a dire situation, and the world was looking at a dire situation. Forget about the economic disaster that was in front of us, but we were looking at people's clinical health. And our number one objective was to keep patients safe, keep our staff safe, keep the doctors safe. And we had to take care of people at the same time. My orthopedic trauma surgeons are operating on patients with the virus. We don't know if the smoke from what we call the bovie that helps cauterize tissue can cause injury to the lungs of an orthopedic surgeon. Were we risking our lives? We saw a lot of the healthcare workers on television get sick. So we had that whole issue to deal with. Then we had to deal with the fact that we couldn't pay our bills. Then we had a situation where no one could pay their bills, but people need health care. And one thing, so I've learned a few things. Number one, if you put off regular maintenance orthopedic care, the problems are more significant. If you have someone with, I'm a spine surgeon, with a spinal deformity that's progressive, or a neurologic weakness that's progressive, and they're afraid to come into the hospital, by the time you get to them, it may be beyond what you can do to remedy the situation. You may not be able to correct the deformity. They may continue to have a weakness that they may not would have had if we had intervened earlier. We saw that with all the medical comorbidities, people's diabetes, people's heart disease, people's high blood pressure, COPD, all these manageable problems became more difficult to manage over time. So we saw that going on. But there's always a positive side. So number one, we became much more efficient. I mean, we had to do more with less. That was the first thing. We had to develop the concept of using telemedicine. Like, what is telemedicine? What are we doing now? We're speaking into a microphone and we're communicating through the radio waves. We had to basically talk to a patient at a distance, try to understand exactly what's going on with them, and try to take care of them remotely. And then we had to do things we've never done before. We had to make diagnoses remotely, and then we had to bring people in for emergency care remotely. I would say 50 to 60% of the people I operated on over the last 6 months, I met the day of surgery. These are people with progressive neurologic deficits. And we got good at telemedicine. We got good at validating how to do a neurologic exam through telemedicine, sending a kit to a patient's house where they had bands to pull to measure their strength, where they took monofilaments on their skin. We couldn't do reflexes, but we could see range of motion of a joint. We could see how people ambulated. So we had an understanding, okay, I have pain in my leg. This is what the MRI looks like, and this is what I could do with my left leg. And we can make a diagnosis. You have a symptomatic disc herniation. Let's treat you non-operatively, physical therapy, anti-inflammatories, epidural injections, and then we can indicate them for surgery after describing the alternatives and the risk of surgery. So we learned that we had this new technology. And then how does that translate today? Well, now, if you live 3 hours from Philadelphia and you have to come see me, well, maybe you don't have to get in the car to see me. Maybe you can go to work all day long, and between 2 o'clock and 2:30, you can have a telemedicine visit with me, and I could help you with your problem, and you don't have to drive 3 hours to the office, 3 hours back. And of course, park your car, pay for city parking, and then wait an hour and a half in a physician's office to see them. So I think we've changed the dynamics. We've transformed medicine for the better. Now we have to fight the legislators. We have to make sure the governments support this. We have to make sure the insurance companies support this. Patients are into it, and physicians are into it. So that's the lemonade we made out of lemons from this catastrophe that has occurred and still continues to badger us as a society.
Just to go back again, speaking about the telemedicine, because, it is really the future, everything that we're doing, whether it's kids, online learning, and, things kind of happened whether we as a society wanted to or not. So did you find with telemedicine, was this something that was always kind of in the works with Rothman? And then all of a sudden, it happened, and then we kind of just had to hit the gas and kind of transition rather quickly, or, what was kind of the timeline with that, or was telemedicine something happening in a few years, or was it, again, just because this happened, you guys found that you had to pivot?
Very perceptive. So the concept of telemedicine came across our desks, I would say, about 5 years ago. And it was just sort of like this concept out in space. And we started to do research. So like in spine surgery, we would do a neck operation. And then we'd say, okay, you don't have to come for your post-operative visits. Let's do a telemedicine. And then we'd sit around and say, okay, let's schedule that at 9 a.m. Let's do a telemedicine. So we'd run around the computer, and then you'd see the patient on the computer. Hi, how you doing? You're waving to each other. And then on the right of the face, you saw the pictures of the x-rays. You're like, oh, your x-rays look great. Congratulations. Everything went great. And then we'd high-five each other and say, that's great. And then we put it away, and we never looked at it again. That was telemedicine before the pandemic. That changed because now we realized, okay, we have to do everything that same way. So we went out and we started to say, okay, besides just saying hello and looking at your incision, now I have to see, how do the joints work? How do the muscles work? How do I do a sensory examination? How do I get this patient to upload with whatever technology they have, their iPhone or a local imaging station, to upload their pictures so they don't have to come into the city to drop their x-rays off. And then I had to learn how to communicate effectively so they had an understanding of exactly what was going on. And then it was great. I was able to bring multiple family members in because they can call into the telemedicine. So now you could talk to 5 people at once, and you could talk to the families and get questions. So we became really good at telemedicine, and that technology is evolving. I mean, I want you to keep in mind, before this pandemic, what was the number one way of all of us getting together, speaking in a business setting online? It was Skype. Skype is gone. Now it's Zoom. Companies weren't nimble. They didn't transform. They didn't adapt. So I've seen 4 or 5 telemedicine companies come and go, and we're learning. The perfect telemedicine for me is like a virtual 3-dimensional telemedicine where I'm in a virtual room with a patient, and we see the avatar of the person we're speaking to. So you have a conversation. You can do the range of motion. And the computer, when you lift your arm up or bend at your elbow, the computer tells you how many degrees it is, because the computer uses artificial intelligence learning modules to teach us exactly what's going on. So through pattern recognition, I can really see what's going on with the patient now. So that didn't exist in March, but exists today. Now, what we have to do is we have to keep the momentum going, because 30% of my office hours today are telemedicine. I want it to be 50%. We're 60%. This is an incredibly new technology that has transformed medicine for the better, and that's part of value-based healthcare. Because let's look at the value. Patients don't have to leave work. They can go to work that day. They can develop an income for their family. They don't have to get in a car. They don't have to spend time. They don't have to wait in an office. They don't have to pay for parking. They don't have to do all the things. And now during the pandemic, they don't have to be exposed to someone who may have the virus. That's value-based healthcare. And it costs so much less to do. So the insurance payments are lower. The cost of the patient's lower. My overhead is lower. That's value-based healthcare.
So I'm not sure, but I think most people do know that you're still a practicing physician, but again, you are also the president. So, and you were kind of just talking about different things where there's overlap. Where does Dr. Vaccaro, the spine surgeon, come in, and then Dr. Vaccaro, the president? So how do you juggle that?
Yeah, fortunately, there are more similarities than non-similarities. So in medicine and in being the president of a medical group, you have a mission statement. We want to provide the best musculoskeletal care possible to people within our communities. We have a vision where we want to go. We want to bring our platform to communities around that we think we can benefit the populations with. And then you have the values, and the values aren't changed. Physicians have the same thing. Our silos or the areas that we really focus on in medicine at the Rothman Institute are patient care excellence, research, teaching. So that is exactly what the Rothman Institute as an organization does. We're focused on clinical care, we're focused on research, we're focused on education and teaching. So the similarities are there. As the president, I have to silo my time. So in the morning, I have a very simple day. I wake up at 4 o'clock in the morning, I go to the gym every day. Now, I don't like to exercise that much, but I go to the gym. So I'm not killing myself. In fact, some days I don't even break a sweat, but I go to the gym every day. Let's just focus. I won't tell you what I do at the gym, but I go to the gym every day.
That's fine.
So I'm there for about 40 minutes, and it's usually, I have a cycle bike with a computer on it that I do my email when I'm doing cycling. Now, if I tell anyone that, they think I'm a loser, but that's what I do. So that starts my day. So I'm cycling. I jack it up to 16 or 17. I may sweat or may not sweat. So I go through my email and I can answer it. And it's not one of those cycle bikes where the computer jumps up and down. It's actually an interesting setup. And then I have my first conference call after I take a shower at 5 a.m. with the CEO of the Rothman Institute. So from 5 to 6 a.m., he and I talk about business that day. And that's the greatest time of the day because we have already communicated through email because we've been sending each other emails since the evening before. So we kind of know what the business plan is for the day. And then after that call, I start my surgeries at 6:15 in the morning. And I do 4 spine surgeries a day, 3 days a week. And I'm usually done, like you and I are speaking at 1:30. I'm usually done by 12 noon every day with 4 spine surgeries. And then I sit down and I start my business day. And it's meetings. Before the pandemic, it was 4 days a week. I would do a dinner meeting. After I'd go home and have dinner with my family, I'd then go out for 45 minutes at a local restaurant for people flying in. So it was easy to bring both worlds together. And before I became the president, I was doing a lot of trauma. And trauma is unpredictable. Trauma comes in every day. And now the younger surgeons are doing the trauma call. And I spend more time managing the group, so I'm doing less. So I don't have an unpredictable schedule. So once I go home, I go home. And I'll only get called if I have a problem with my personal patient. So it's easy to bring both worlds together. And I think it's important for a very successful orthopedic surgeon to run a large practice is to be a practicing orthopedic surgeon, because when I'm in the operating room and there's some problem with workflow or efficiencies or things are just not gelling, I see it firsthand, I experience firsthand, I can communicate with all the players, and I can affect change. If I'm sitting in office and someone comes in and says, listen, the turnover time is so inefficient, we have to wait an hour and 15 minutes and I can't get anything done, I'm like, what are you talking about? And then now I have to go interview everybody. And then I hear 12 different versions of the story. I don't know what's going on, but if I live it and breathe it, I can understand it and then I can change it. So my world is great, and I hope I'm healthy and fit to continue to operate until that is no longer the case. So I think it's a great combination of work responsibilities.
So how many hours a night do you sleep with all that?
So I've never slept that long, and I don't know when that began. I blame it all on our archaic training that we went through before mandatory work hour restrictions were in effect. But in my day, now residents can only work 80 hours a week, but in my day there was no limits. So we would stay up every other night, and which was cruel and unusual punishment. And everyone would, no one argues that. It was like crazy.
Right.
And I think that most of us develop a sleep disorder. Now the question is, the lack of sleep is not good for you in terms of your mentation, in terms of your physical performance. But my body has been used to getting 4 hours of sleep a night, and I've been getting 4 hours of sleep a night forever. I covered the Eagles. I'm the spine physician for the Eagles. I was at the Eagles game. It was a night game. I got home at 12:30. I went to bed, and I woke up at 4:15 without an alarm, and I felt great because I'm used to it. I'll probably drop dead right after this interview, but
right.
I'm used to it, so it doesn't affect me.
This is the hardest part of your day right here, right?
Exactly. Yeah, so you get used to it, but I always said to myself, when did this start? Because when you're in high school, you sleep until 11 a.m. every morning. So and then I guess it must have started in med school and as a resident, because I'm sure college I was sleeping late, missing class, like they all do. I guess it must have happened, but that's when I think it happened. But I think a lot of surgeons are the same way. We get used to not having much sleep, which is probably not healthy, but we get used to it, and we're functional and efficient in that respect.
Okay. So want to look towards the future a little bit. So what are you most hopeful for this year?
I'm speaking to you today, and I'm looking up at the monitor, noticing that the stock markets are crashing. I was hoping that the beginning of January would be beneficial for the world, and I hope we politically we come together. We're not polarized. I hope in medicine all the stakeholders come together. The stakeholders are patients, doctors, payers, the government, and insurance companies. We have to remove conflict in almost every area of business. And if you look at the industries that have done poorly, the restaurants, travel, entertainment, and then sports. And I just hope for their sakes and all the people that are suffering come together. So what do I want specifically for the Rothman Institute? I want to open our doors. I want to bring people who want to come into our offices. I want people who want to take advantage of telemedicine, take advantage. I want to grow the Rothman Institute because I think we have the right platform. I think when you base a practice on more than just excellence in clinical care, but in research and education, you benefit societies and communities you go into. So what I'd like to do is I'd like to see our business grow into other states that admire our business model and appreciate the care we provide for patients.
Personally, what would you consider a success? Not necessarily for organization, but for you, if you look back or look forward to December 31st, 2021, and you look back at the year, what would you think wow, this was a successful year? What does that look like to you? I
saw the sadness from an economic perspective of those that got furloughed. And I saw people financially suffer. And, physicians are in a different economic situation than non-physicians, but these are people coming out of medical school with debts of $400,000 a year, and people not able to pay their mortgage or, pay for because they have to pay educational loans, and then all of a sudden they're furloughed. And so let me explain to the listeners what furlough means. Furlough means you get paid no salary, but we cover your health care. I mean, that's crazy. Imagine going to 4 years of medical school and going through internship and residency and not having a job. Not because the economy is doing poorly, it's because a pandemic exists that we just can't get together. So what would be a satisfying year for me is that everyone goes to work that can work, every able-bodied person participates, contributes, and does the best they can in terms of providing care for patients. And we don't have to walk up to anybody and say, listen, you need to go home today because it's not safe. That would be a satisfying year for me.
Definitely. I think that's something that we can all kind of get behind. So is there anything else you would like to add for our listeners?
I just want to say that this podcast that you've done, I think it's a great idea to get the voice out of individuals that have something to say. I mean, I'm speaking from the perspective of a doctor and the president, but I've looked at your celebrity list of people you're interviewing, and I think you're contributing greatly to getting the word out for the voice of medicine and orthopedics. So I have to congratulate you on how innovative you have been, Alex, and you're doing a phenomenal job.
Thank you. I appreciate that. Now you're putting me on the spot. So wasn't prepared for that, but no, thank you. This is definitely another, like you said, another way just for us to get our voice out. You know, we have so many great physicians, staff, everything at this organization that I'm coming to learn and to meet. So excited just to kind of help do my part in sharing the good word. So thank you again for being on today and being our official first guest. And hopefully, there'll be many more of these and many more interviews with you.
Thanks, Alex. You have a nice day.
You too. Thank you. All right, so in November of 2020, Dr. Danielle Ponzio performed the first outpatient total joint replacement at the AtlantiCare Center for Orthopaedic Surgery in Egg Harbor Township. So find it's only fitting that she's our first physician spotlight. So Dr. Ponzio, just want to welcome you and thank you for joining us today on the podcast.
Thank you for having me.
Of course. So explain to us, what's the significance of being the first outpatient total joint replacement at this facility? What does that mean?
So it was really exciting because this facility has been something that the Rothman Institute has been working on for quite some time. We built it, designed it for outpatient surgery in conjunction with AtlantiCare, which is one of the big hospital systems in South Jersey that we work out of and do our surgeries out of. But the advantage of outpatient surgery is huge, and being able to offer that in a really beautifully designed facility is an asset to our patients. And that day in particular, doing the first joint replacement in the new center, there was a lot of energy and excitement around that particular day and that patient. Fortunately, the patient was gracious enough to allow us to document his experience, and without a doubt, he had a great experience. He was walking out of the building by early afternoon, and he really made it all look very easy and has gone on to have a very smooth recovery. And so I think that paved the way to opening the doors to more and more patients going forward. And it's really exciting to be a part of that.
Yeah, absolutely. People hear, outpatient, and when they hear total joint, they're hesitant because they don't want to do it because they think there's going to be downtime. They think they're going to be in the hospital a long time, and especially with COVID and being in that atmosphere. So what type of patient is this acceptable for, or who would you offer this to?
Yeah, so we have a set of guidelines that we follow to make sure that we're offering it to the appropriate patient. And that's really all about safety. So we want to be able to offer outpatient surgery, but also to do it in a safe manner and to make sure that the patient's going to have a successful outcome. And, if you don't fit in that group, it's okay. The hospital is still a great place to have your surgery. And that's the way we've been doing things for years. So there's not a downside per se to not be at the surgical center. And really to be at the surgical center, you have to be healthy, not have many comorbidities, be at a healthy body weight, have support at home. And if you meet those criteria, then you would be a good candidate to go home the same day. And I should mention, in the setting of COVID, it does come at an opportune time because there's a lot of patients that are hesitant to be in the hospital. And we've made lots of new rules and regulations around the hospital setting to make it safe. But it is a nice option to have an outpatient setting.
Do you think more people are open to this procedure because of COVID? Like, was this a time? I know, again, this is a new facility that we're doing it here, but do you think people were hearing the same day surgery? Are they just now they hear that we're offering this and people are like, sign me up? What are your thoughts?
There's a lot of demand right now to be at the surgical center. I think, one, because it's new, two, because of the environment that we're in healthcare right now. And so a lot of patients are asking about it and whether or not they would be candidates for it. And I think that's great and it's exciting. We love it. But again, we do have to make sure that it's done in a safe manner and that you really meet the criteria in order to go there.
So interesting enough, we were just speaking a little bit again about the evolution of going from being in the hospital for a long period of time to just, like you said, up and walking within hours of the procedure. So what have you noticed just through your time as an orthopedic surgeon? What some of the other evolutions?
A lot has changed. When I was in training, patients did spend many days in the hospital. Simple things have changed, just the way that we used to close wounds and put dressings on. It used to be something that every day we had to change dressings, and we had staples, and now we use skin glue to close wounds. And so it's aesthetically better, but also just easy for the patient. There's a bandage that's waterproof. You can take a shower right away. You get up and you walk the same day as surgery. We usually use blood thinners after surgery, and that has changed over time from being a really heavy-duty blood thinner like Coumadin to now just using a baby aspirin. And so those things that have changed over time have really made the entire experience something that's better for patients and, in fact, better for their outcomes as well.
Just again, like when we're speaking with the evolution, because I like to say it's kind of like it's not your mama's total joint or your grandmother's like total joint replacement. So I just find it's fascinating just hearing, and I'm also very brand new to the orthopedic world. So hearing again from what my thoughts were or what I've heard, and then just hearing that this is something that we're able to offer our patients. And then just hearing again that what is it like for you being able, like, you're the first, how does it feel to be the first? That's, that's badge of honor. You got to wear proud, right? So how does that feel for you?
Yeah, it's like paving the way. Everybody else,
right.
How did it go?
You're like, I'll be the test dummy, right?
Yeah, exactly. But no, it was a really exciting day. And, that patient, I, of course, let him know that he was going to be the first. So he was expecting all of the fanfare around the day.
Right.
Yeah.
The balloons. Absolutely. Yeah. Yes.
And he really did so well with it. It was great. And I think all in all, that center is just beautiful aesthetically, but it's also comfortable for the patient. And the facility and the staff there are excellent. It really offers a level of quality patient care that is just in line with everything that I've experienced in my years of training. I did my training in Philadelphia at the Rothman Institute for my residency, and I spent a year of fellowship training, which means just joint replacement, just hip and knee replacement training at the Hospital for Special Surgery in New York City. And so those are two really top-notch places, and the facilities that we have created for outpatient and inpatient surgery are really just in line with that level of quality.
So I want to touch on something else. So again, not only were you the first to do this procedure, but you were actually the only female joint surgeon that we have, right, at Rothman. So what made you want to become an orthopedic surgeon?
Yeah, so I would say my career path started at a young age. My dad's an orthopedic surgeon. I grew up in South Jersey, so I've always been local to the Rothman Institute. I was one of 3 girls, and yet I was always the one in the group that gravitated towards wanting to go to work with my dad. And I did. I was able to go with him to the office, to the OR. I visited patients that were in the hospital with him, and even a couple house calls over the years as even a young kid. So the thing that I remember the most is always feeling admiration towards how patients reacted to my dad and the impact that he was having on them. And I felt like I witnessed that in many different ways over time. And so from a young age, I remember wanting to be an orthopedic surgeon. And, it wasn't until I would say my college years where that started to be a more real possibility. It's a good 10 years of education and medical training after high school. I always tried to keep an open mind through those years and see if there were other areas of medicine or even maybe other unrelated fields that I would want to go into. But I always came back to orthopedics. The other influence I had throughout life was being an athlete. I played soccer, I played ice hockey, and I was a college rower. And so those things also fit nicely with the world of orthopedics, insofar that, orthopedics is really about function and getting patients back to the activities that they want to be doing. And so as an athlete, I really relate well to patients that are looking to do that.
I knew that you were an athlete, so I was just going to touch on that. So do you think that you're able to obviously like relate to your patients for that? Like you know what it's like when you're sidelined, when you're not able to perform, or you're bench for an injury or whatever. Is this something that you're able to apply, to your practice every day, because you're like, I know what my patients want because I was in their position?
Yes, absolutely. And I think I have a lot of patients that come to me specifically for that reason, looking to have their joint replaced, but wanting a surgeon who understands their perspective and why they want to get back to the things that they really enjoy. I've done a number of joint replacements on avid runners who really needed some guidance after surgery about how to get back to the level of running where they were. And we were able to do that, and it was really exciting. And I love getting text messages from my patients saying, "Hey, I just ran 8 miles today," and I can say, "Yeah, me too." So it's exciting. And of all of the patients I work with in joint replacement, it's quite an exciting group to work with the athletes in particular. Having said that, I would say that there's such a range in joint replacement, and sometimes the goals are really quite modest, like just being able to independently walk, or to get off of a walker and use a cane, or just maintain your independence at a later stage in life. And those patients, helping them do that is just as rewarding.
Yeah. So you mentioned that you are one of 3 girls, and you also just had a set of twin girls last year. Do you want to explain how's that adjustment been, coming back to work full time and managing they're how old at this point?
Yeah, they are 11 months old.
Okay.
Identical twin girls, and it's been awesome. I mean, it's just been one of the highlights of life. It comes up constantly with my patients. Everybody wants to know how the girls are doing, and I really appreciate everybody asking about it. I feel like they've fallen right in line for the most part in terms of incorporating them into my schedule and kind of balancing work with being home with them. It ends up working out, and I think I've been used to juggling a couple balls in the air all my life, and this is no different. And again, I had my dad as an example from a young age, who was always at my soccer games, and so he sort of set the tone for me as to how to be a good parent. And so I'm doing my best to spend the time that I am away from work with them and watching them learn and grow. It's been incredibly exciting.
That's awesome. And I was going to ask, is there anything what you like to do away from the OR, or what's something that you enjoy doing that people wouldn't think you enjoyed or wouldn't expect from you?
I mean, these days it's really about spending time with the kids, but I'm trying to tie in some of my athletic interests with spending time with them. And in the world of COVID, and I think a lot of people are trying to get outside and do a lot outside. So one of our new interests has been hiking, and we've got some nice packs to put the kids in and kind of take them everywhere to explore as much as we can. I'm also commonly found out on the streets here with my double stroller, running, pushing the girls, or biking with them in tow. So I would say that those are the activities that I'm spending most of my time doing. It used to be the dog, but now it's the kids, and sometimes the dog too.
Yeah, I've seen plenty of those mothers that have like the double strollers with the dog, and I have one dog and I can't even do it with hers. I commend you for doing that.
I know.
But what are you looking forward to this year? Anything personally, professionally?
So, and I guess in my personal life, I'm looking forward to the girls learning how to walk, the twin girls learning how to walk, and I'm hoping to get them on a pair of skis once they're up and walking. So that's, I'd say, one of our goals as a family. And then professionally, I think just continuing to develop what we started with the outpatient surgical center. and sort of finding a new balance between directing some patients to that facility and continuing to facilitate good patient care in this environment that we're living in with COVID amongst us.
Awesome. Well, I just want to thank you again for joining us. It's been great talking and chatting with you and working with you, and appreciate your time again for joining us on The Breakdown.
Thank you so much for having me.
All right, so next up we have Dr. Asif Ilyas. He is going to discuss for our next segment the Medical Incredible, the wide awake local anesthesia, no tourniquet. So I want to pull a little excerpt from this article that you sent over from the New York Times back in March of 2017. Proponents like Dr. Ilyas praise awake surgery as a step forward in transparency. It's all about communication, comfort, and experience, he said. It is definitely catching on and creating a different kind of surgeon-patient relationship. Thanks again for joining us today, but would love just to hear your thoughts on what you were thinking when you said that, and what exactly did you mean about, the different kind of surgeon-patient relationship?
Thanks, Alex. Yeah, so the wide awake hand surgery is a really interesting and a fun area that we've been developing here at Rothman Orthopaedics. It's not a new technique in the sense of doing surgery under local anesthesia. Has been done in different forms in different areas, but what we're doing is trying to normalize it and also expand on what we can do. And just to kind of step back a little bit, so what wide awake hand surgery means is that first of all, you're literally wide awake. So during the entire surgical experience, you're awake for it, and only the surgical site is anesthetized. So in comparison, most hand surgeries and most orthopedic surgeries for that matter are done with you either fully asleep through general anesthesia or sedated through medication and then blocked in your surgical site, whatever limb that your surgery is being performed in. In wide awake hand surgery, there's no general anesthesia, there's no regional anesthesia, there's no proximal block, there's no sedation. What we do is inject the surgical site with just a local anesthetic. But what we do in addition to that is add some agents that kind of add to the anesthesia in the surgical site. Specifically, what we add is two things. One is bicarbonate, and two is epinephrine, also known as adrenaline. So what the bicarbonate does is it neutralizes the acidity of lidocaine. So lidocaine is a very common fast-acting local anesthetic that when injected makes your whole surgical site totally numb. But it burns when you receive that. It's a very painful injection. So that's one of the reasons why people are often sedated before they receive lidocaine injections or regional anesthesia. So adding the bicarbonate decreases that burning feeling and feels like just water being injected into an area. So it's much less painful. The second thing is we add epinephrine. Now, adding epinephrine, what that does is decrease bleeding in the surgical sites. So one of the reasons we sedate people is that we do surgeries with tourniquets on. So we apply tourniquet to the upper limb, like the upper leg or the upper arm, and that controls the bleeding in the area where we're working. By using epinephrine in the surgical site, we don't need to use a tourniquet, which also prevents us from having to sedate the patient. So the combination of lidocaine, bicarbonate, and epinephrine together allows us to do the surgery completely awake. And also there's a little bit more in terms of technique, how we inject, where we inject, et cetera. Now, one more kind of background thing, Alex, is when we talk about hand surgery as a field is pretty broad. It's basically conditions of the hand, wrist, and arm, be it, arthritic condition, fractures, nerve problems, tendon problems, soft tissue problems, tumors, et cetera. But when we talk about wide awake hand surgery, we can apply this technique to many things across the arm and hand, but we really focus on the hand where there's a lot of high volume surgeries we do. Any procedures of the fingers, from simple procedures such as mass excisions to trigger finger releases, to even amputations and mass excisions and tumor excisions, we can do under straight local anesthesia and wide awake hand surgery. So to answer your question, how this is different is several things. One is obviously the anesthetic experience we talked about. But two, it is safer for the patient, so they don't have to have anesthesia and the complications potentially related to that. And I say that with the understanding that anesthesia is very, very safe. And I'm not talking about major complications. I'm talking about even minor complications such as, nausea, vomiting, constipation, et cetera, dizziness. We can avoid all those things. Secondly, they can participate in their surgery. So they can see what's going on. I can communicate with them during the surgery. I can tell them what I'm seeing, what I'm doing, what I'm finding. So they have this better engagement in terms of what happened and what they need to do afterwards. There is a convenience factor to this. They don't have to be fasting. They don't need to have a ride in or a ride home. They don't have to go get more testing done preoperatively, blood work, EKG, chest x-ray. They don't have to see consultants, etc. And there's also a cost advantage. They don't have to pay for an anesthesiologist. They don't have to pay for additional testing. They don't have to miss as much time off from work. So there's a lot of advantages. So that's what I was getting at, that it's an advance in terms of how we do it. It improves the patient experience, patient safety, and patient engagement.
So my biggest question, you were talking about obviously with the numbing of all, you mentioned what, the lidocaine, what else?
Right, it's a combination of the lidocaine, which is the main agent,
Right.
and then the bicarbonate, which is the buffering agent, and then the epinephrine, which is what controls the bleeding.
So what exactly, and again, what stuck out to me as you were mentioning is pretty much they're all used in combo with each other just to kind of counteract and make sure that the patients aren't receiving the burning. But I'm curious to know during the procedure, I know you said you're talking with them and you're communicating with them, but what are they actually feeling? Like, what are they able to do? You know, obviously they're kind of just hanging out and this is happening, but what else is going on?
So, number one, they're fully awake and they are engaged as much or as little as they want to. Most are fairly engaged, and I'll keep them engaged and I'll tell them what I'm doing and what I'm finding. It's particularly useful when we're doing a procedure where we're not exactly sure what we're going to come across, and we can relate those things to them. Some folks, if they don't want to be particularly engaged, they can do other things. They can listen to music, they can play on their iPad, etc. But for the most part, I would say most patients are fairly curious and engaged with what we're doing. Where it's really, really helpful from both a surgeon and a patient perspective, an additional advantage above the things I talked about in terms of safety and convenience and cost, is checking the quality of our work. So for example, let's say someone has a laceration of their forearm or their hand and they cut a tendon that moves their fingers or their hand. After I do the repair, I'll then ask the patient to move that structure. And I'll say, move your finger, move your wrist, move your hand, and we'll check how well it's moving. We'll check the strength of the repair, and I'll even show them what the repair was, and so they have an appreciation for it, and they'll know when they start their rehab what that entails. And sometimes we'll do that and we'll realize it's not strong enough, or it's too tight, or it's too loose, or it's too bunched up, and we can make those adjustments immediately, which if they're asleep, we wouldn't be able to have that advantage. So that's really helpful when we're doing, say, a tendon release or a tendon repair, or even what's called tendon transfers, where I'll move tendons from one uninjured part of the upper extremity to another one to restore loss of function. We can immediately then test and make sure that we got the right tension and right position.
Have you had any interesting cases during this procedure? I know you said it's not exactly a new one, but with that being said, I'm sure you've witnessed a few things over time.
Of course, let me have a number of examples to give you, but firstly, when I say it's not new, what I mean by not new is that the concept of using lidocaine for surgery is not new. Where it's new is its increased use in orthopedics, and particularly hand surgery, for the reasons that we talked about. And I think that here we're really championing that and really showing some significant advantages, and it's being borne out in our research as well. From a patient perspective, there's several really interesting scenarios where it comes in particularly helpful. One is in the scenario of older patients and or patients who have a lot of medical conditions who are not safe for surgery, who need a lot of precautions or may not be cleared for surgery, etc. Because we're not anesthetizing them, we can proceed without having to do the traditional clearances. So that's really helpful. Another scenario where it's really helpful is in the opioid addiction space. And as you know, I do a lot of work around opioids and pain management and opioid abuse, opioid addiction. A lot of folks are worried about their pain experience and want to have a surgery with minimal pain and less reliance on opioids afterwards. Or they may be recovering and they can't have opioids at all. And this is another technique where we can use a combination of short-acting and long-acting agents to really help better control their pain. And we're seeing good pain relief from this technique as well. And lastly, I do a lot of professional athletes. And it's interesting, professional athletes run the gamut in terms of different injuries and different types of personalities and expectations. And a lot of them also don't want to be asleep, and also are very curious about, what their injury is. And we can do these procedures with them awake, and And I always find them to be really interesting patients in terms of being curious about what it is. And I find it really helpful because they have a better appreciation of the injury than the repair, so that when they're, going through their rehabilitation, really appreciate it more.
What's one thing you would tell a potential candidate about this procedure, kind of just to ease their concerns?
For most patients, we ask to have it done this way because of just the reasons we've talked about. But I think that one of the misconceptions that they're going to be feeling everything when they're having surgery. I think sometimes people relate it to their experience in the dentist's office, and I've had my share of bad experiences in the dentist's office as well. And the main thing I would tell them is that besides the advantages of being, more safer and more convenient and more inexpensive for you, it's from a pain experience, it is excellent. You will feel nothing during the procedure, and if you happen to feel something, then you and I are talking during the case. So you can always just relay that directly, and we can obviously make adjustments to correct that.
Awesome. Well, I'd like to thank you again for sharing about the wide awake local anesthesia, no tourniquet surgery, also known as the wide awake surgery. And again, thanks, Dr. Ilyas, for taking the time to talk with me today.
Thanks, Alex. It's my pleasure.
Thank you. We'd like to thank Dr. Vaccaro, Dr. Ponzio, and Dr. Ilyas for joining us today on this episode. For more information about each of them and other services we offer here, please visit rothmanortho.com. That's rothmanortho.com. Thanks again for listening, and until next time, take care.